Welcome, everyone, and thank you for joining this evening's webinar. We are thrilled to have Drs. Brisman, Mikolenko, and Wu here to share their clinical experiences with the diagnosis, medical management, and operational treatment of patients with trigeminal neuralgia. Whether you are directly impacted by facial pain or simply interested in learning more, we're grateful that you've taken the time to join us tonight. My name is Brandy Underwood, and I serve as the Manager of Development, Research, and Advocacy for the Facial Pain Association. Before we begin, I would like to share some exciting updates from the FPA and go over a few housekeeping items. October is Facial Pain Awareness Month, a time to raise awareness and recognize the many members of our community who live with facial pain. We are wrapping up Facial Pain Awareness Month with tonight's webinar on the management of trigeminal neuralgia. It is the final in a series of 3 webinars, and you can access the recordings at facepain.org. We are also excited to announce the launch of our second book, which focuses on living well with facial pain. We are incredibly grateful to Ann Simnacki, Secretary of the Facial Pain Association Board of Directors, an FPA peer mentor and support group leader, and co-editor of Facial Pain, a 21st Century Guide, as well as its new companion, Facial Pain, Living Well with Neuropathic Facial Pain, including Trigeminal Neuralgia, as well as Medical Advisory Board member Dr. Jeffrey Brown and guest editor Dr. Beth Darnell, who is also a member of our MAB, for their dedication in bringing this book to life. Additionally, we have launched our online shop. By clicking the shop button in the top navigation bar at facepain.org, you can explore the newest addition to the FPA website. There, you will find both books, as well as a newly released FPA Awareness Month t-shirt. Throughout October, you can purchase the new book at a 10% discount. We are also offering a bundle with savings to purchase both books at once. We hope you'll join us in spreading awareness this month. If you feel ready to share your story on social media, please tag us so we can share it too. This month is incredibly important because it is our chance to let others know about facial pain, what it is, and how it affects our community. This is crucial for promoting faster diagnoses and raising awareness about the daily challenges faced by those living with facial pain. Now, to go over a few housekeeping items. If you have any questions, please use the Q&A feature at the bottom of your Zoom screen. We will have a dedicated Q&A session at the end, but please feel free to submit questions throughout the presentation. We encourage you to connect with other members using the chat feature throughout tonight's webinar. Today's webinar will also be recorded and available on our website in approximately 1 week. Now, it is my honor to introduce this evening's speakers. Dr. Michael Brisman is board certified by the American Board of Neurological Surgeons, a fellow of the American College of Surgeons, and specializes in the treatment of trigeminal neuralgia and brain tumors. He serves as the co-medical director of the Long Island Gamma Knife Center at Mount Sinai, South Nassau in Oceanside, New York. Dr. Brisman is the author of Put Down the Knife, a fresh look at adult brain surgery, a new medical textbook which promotes the importance of minimally invasive procedures and conservative treatment options. In addition, he is a past president of both the Nassau County New York Medical Society and the New York State Neurosurgical Society. Welcome, Dr. Brisman. Dr. Ivan Mikolenko is an experienced neurologist who has been treating patients with various neurological conditions, including neuropathic facial pain, for nearly 2 decades. He completed his medical education at the State Medical University in Ukraine, followed by residency at the Johns Hopkins University School of Medicine in Baltimore, Maryland. He is a member of the American Academy of Neurology, the Neurocritical Care Society, and the Johns Hopkins Medical and Surgical Association. Dr. Lisa Wu has more than 15 years of experience in state-of-the-art external beam radiation therapy and gamma knife stereotactic radiosurgery. He brings a diverse background in community practice, research, and academic training to Mount Sinai South Nassau's Radiation Oncology Department. Dr. Wu was the recipient of numerous honors throughout his undergraduate work at Harvard University and while he was in medical school at the University of Pennsylvania. He completed his residency at Columbia University Medical Center in New York, New York. Again, we are thrilled to have you with us here this evening and hope you find this session helpful. Without further ado, let's get started. Doctors, please take it away.
Thank you. So, thank you so much. Can everyone hear me okay? Okay. Dr. Michael Brisman. So, I'll be speaking to you about trigeminal neuralgia. I got interested in trigeminal neuralgia from my father, who was a world expert in trigeminal neuralgia. I'm one of the few neurosurgeons in the country, I think, who specializes in trigeminal neuralgia. It's the main thing I do. And I offer diagnosis of trigeminal neuralgia, medical management, MVD, rhizotomies, glycerol, radiofrequency balloon, as well as gamma knife. And I hope that my experience can help people. I've treated thousands of patients. You know, people often say that they're thankful that I'm helping them, but the truth is I'm thankful to be able to help all of you. So without further ado, next slide. Okay, so trigeminal neuralgia is in a category of conditions that are usually caused by compression of a blood vessel against the nerve where it comes out of the brain. That also include hemifacial spasm, a twitching of the face, and glossopharyngeal neuralgia, which is a pain that involves the back of the throat or the deep ear. Next slide. So there's a differential diagnosis. There are many other things that can cause sharp facial pain, and I list many of them here. And the point is that it's critical to get the right diagnosis. I think there's a certain pathway that we're going to use for trigeminal neuralgia and a certain pathway we would use for everything else. So critical to get the right diagnosis. Next slide. There's also a differential of things that cause pain in the face that's more of a dull type of pain, the most common being dental pain. Next slide. So the features of trigeminal neuralgia that must be there, it must be a painful condition in the distribution of the trigeminal nerve. So the cheek, the jaw, the forehead, the top of the head, they must be sharp, severe, intermittent, sudden, and brief. There can be other features to it, but it must have those components. Next slide. Usually it will be described as electric shock or stabbing, often radiating, triggered by light touch. There'll often be spontaneous remissions where it can go away on its own for weeks or months, and often responsive to anti-seizure medicines, Tegretol or Trileptal. Next slide. It can also have some constant components or dull and achy components and some intermittent numbness. Next slide. The cause is usually it's a blood vessel compressing the nerve, but it can also be from multiple sclerosis or mass compression like a tumor, and sometimes we don't know the cause. Next slide. The treatments, one is observation. Sometimes it goes away on its own. The first line is going to be medicines, anti-seizure medicines like Tegretol, Neurontin, and procedures such as moving the blood vessel away, called the microvascular decompression or MVD, or nerve injuring procedures like nerve blocks, which can either be done with a needle in the cheek called percutaneous rhizotomy, which can either be done with radiofrequency, which is a heating technique, glycerol, which is an alcohol injection, or balloon, where we inflate a little balloon against the nerve, or a stereotactic radiosurgery like gamma knife, where we aim some focused radiation beams on the nerve. Next slide. Indication. So usually there's people with vascular compression, young, healthy people, not people with MS, usually people who have not had a prior MVD, ideally good hearing in the opposite ear because there's a tiny risk of decreased hearing with the procedure, and some tolerance for such a procedure. Next slide. This is just a cartoon of what the operation looks like, where at surgery, which we do with a microscope, we could see the blood vessel, usually the superior cerebellar artery, that is pinching into the trigeminal nerve, and then we put a little sponge, the white thing, between the red blood vessel and the yellow nerve. Next slide. And this is just showing a picture of a patient that I recently treated, where you can see on the left is the artery, the superior cerebellar artery, that's pinching into the nerve, the white structure, and it's indenting and distorting the nerve. And then after I move the blood vessel away on the right side, you can see the nerve is all happy. It's not distorted anymore. And all the way on the left is a little piece of white Teflon felt that's keeping the artery away. And this patient got all better. Next slide. Other options include the percutaneous rhizotomy or the radiosurgery. The percutaneous with the nerve block with the needle gives faster results, can usually stop medicines, but it's a bit more invasive. There's some tiny risk of bleeding or infection in the head. The radiosurgery, the focused radiation, can take a few weeks to work, and often you still need some medicines, but it's a bit less invasive. Certainly a good choice for people who can't come off blood thinners or are sicker. Next slide. And the nerve injury procedures, the radiofrequency does have the ability to be selective. So like if someone had pain just in their chin or their cheek, we could select that area only for targeting, whereas the others really not. And the radiofrequency also does need a little cooperation in the operating room, but they're all good options. Compare with the MVD, the nerve block procedures have less major risk, but the downside is more chance of needing repeat procedures because the nerve can regrow, and more chance of some numbness because we're purposely trying to injure the nerve. So usually young, healthy people, the MVD, if the medicines aren't working or they're bad side effects, MVD is a good choice. For older patients, sicker patients, or patients with multiple sclerosis or an underlying tumor, the nerve blocks or radiosurgery might be a better choice. Next slide. This is sort of showing what the nerve looks like coming out of the brain stem and then branching off into the three divisions, the first, second, and third, often called V1, 2, and 3. V is the Roman numeral for 5. And the bottom division, the third division, goes out of the skull through an oval hole called the foraminal valley, and that's where we can insert the needle to do the nerve block. For the MVD or the focused radiation, we address the nerve right where it comes out of the brainstem, but the nerve block goes into the foraminal valley and approaches the nerve that way. Next slide. And this is just showing how the needle, once it gets into the foraminal valley, can theoretically address issues with all three branches of the nerve. Next slide. And this is just a depiction of, in the operating room, how the person's sedated. We're using the fluoroscopy, which is live x-ray, to ensure the needle's in the right place. The needle is in place. Next slide. This is just one of my patients showing under x-ray guidance. We can see with the bony landmarks where the needle is going to be sure it's in the right place. Next slide. So the concepts of the nerve injury are that the more injury we make, the more likely we'll get rid of the pain, but also more likely to have lasting relief, but also more likely to get numbness and dysesthesias, which are bothersome feelings. And also we know that a small injury can totally eliminate the pain. And it's also hard to totally assess how much injury we're doing during the procedure. So as a rule, we want to err on the side of doing a smaller injury because we can always come back and do more, but we don't want to over-injure the nerve. Next slide. The stereotactic radiosurgery or super focused radiation, the key features of this is very different than regular radiation. It's very conformal to the target, and the fall off radiation is very quick. So there's little radiation that goes to other areas of the brain. Next slide. And these are just different types of machines can be used for this. The concept is usually a convergence of beams on the target. Usually we're using gamma knife, linear accelerators, which emit x-rays like CyberKnife and Novalis are usually I use that for other things. And then this proton beam is usually used for other indications besides trigeminal neuralgia. Next slide. And radiosurgery we can use for different things besides trigeminal neuralgia, including brain tumors, vascular malformations, and we can also use it for spine tumors and also for other body things. Now, I only do it for brain and spine, when people are doing just prostate, they would use, other doctors besides me. Next slide. This is an example of a patient I treated with Gamma knife, and the you can see how we can really see the nerve nicely. The green is where we're aiming the radiation. This is a patient of mine who I treated and had good relief of pain, and 15 years later still has good relief of pain. Next slide. So the treatment of facial pain that is not trigeminal neuralgia, very, very different. And again, I want to emphasize how important I think it is to get the correct diagnosis before we talk about anything else. And I also would say that atypical, people define things differently, but for me, atypical trigeminal neuralgia is still trigeminal neuralgia, but the person may have some constant features of pain, some achy features, some numbness, but they still have the sudden, brief, severe shocks of pain responsive to Tegretol. And that can be treated with those procedures. People who have something else should be treated differently. So option one is observation. Medicines like gabapentin, Neurontin, Elavil, Topamax, and Cymbalta can be considered. Rarely we would consider neurostimulation, but that again is rarely what we're using. And again, I really want to emphasize how important it is to be certain what the diagnosis is. Next slide. So again, correct diagnosis is critical. Flexibility of treatment is critical. Complication avoidance and surgeon experience. I do believe that because I've been doing this for 26 years, because I specialize in trigeminal neuralgia, because I offer all the modalities, that I do think that helps me to help you. And I do think that gives me, a bit of an edge, though I'm not going to say I'm the only person who can treat it, but and I'm always available to help people. Just so people know, anyone can email me, anyone can call me. I do FaceTime visits. People can call me on my cell phone. I don't have any secrets. There shouldn't be any secrets here. And I've written a book. And there's a big section on trigeminal neuralgia, but so important. I've seen so many people, have issues because either they were incorrectly diagnosed or the procedure wasn't done, in the best of hands. And there's always going to be some complications. I'll also say, and I think this has helped me too. I mean, in addition to having a father who specialized in trigeminal neuralgia, I personally, the last 5 years, have unfortunately suffered from a chronic pain condition myself. Not trigeminal neuralgia, but I will tell you that has really, in many ways, I mean, I'm almost like thankful that I had it, because I really feel that it helps me to help my patients better. I've gone through a lot. I can really empathize with what it means. I mean, you don't really understand, even the years of taking care of people, I didn't really understand what it was to live with a severe chronic pain condition until it happened. And thank God I'm in a much better place now. But I've tried a lot of the things that my own patients with facial pain have, and I feel that has really helped me too. I also feel, by the way, that my team has helped me, that working with excellent people like Dr. Wu, with Gamma Knife, with Dr. Mikolenko, with all the wonderful nurses, with the people at the Facial Pain Association, have also made a critical, have had critical help with the work that I'm able to do. So in any event, I'm here to do, my life, one of the biggest things in my life, in addition to my family, is trying to help people with trigeminal neuralgia, facial pain. I'm at your service, and that's it. Anything we could do, and I hope this seminar is helpful. Next slide. Thank you. And maybe we'll let Dr. Wu speak next, and then I think we were going to start to take some questions.
Great. Thanks, Dr. Brisman. Let me share my screen real quick. Okay, hopefully everyone can see that. And so again, thanks to FPA. It's an honor to be with Drs. Brisman and Dr. Mikolenko to spend some time with you to talk about trigeminal neuralgia from a radiation perspective. I think it's worthwhile to talk a little bit about the role of radiation. I think it does have a place in the armamentarium for the treatment of trigeminal neuralgia. And a lot of times I find that patients come in with some misconceptions about radiation, and understandably so. I mean, I think at first blush, most people kind of have this negative connotation when they hear about radiation. So I'm glad to have this opportunity to spend a few minutes with you. My disclosure slide. So real briefly, what I hope to go over is just a brief definition of, what is radiosurgery? Some people say, is it surgery? Is it radiation? Is it something else? We'll talk a little bit about what Gamma Knife is and how it works, since that's the platform that I'm most familiar with. I've done it in my years of practice, and then prior to that in my training. And then we'll talk a little bit about, what is its role in trigeminal neuralgia, its ability to effect pain relief in patients with facial pain, side effects, who should you consider for radiosurgery. So it's a confusing marketplace, I have to admit. There are a lot of different machines. Dr. Brisman, his slide set had shown you 2 or 3 machines that provide stereotactic radiosurgery. In reality, there's more than that. There's more than even what I'm showing you on the slide. I have 6 machines that are out here, and there's probably a couple more platforms that are out there. So it can be confusing to the patient because a lot of these machines have marketable names, Gamma Knife, CyberKnife, Valus, TrueBeam. So I think it kind of muddles for the patient who's not aware of what all these machines do. I think it kind of can be confusing. So what I think is most important is to define what is stereotactic radiosurgery. And as Dr. Brisman had hinted at, it's not typical radiation. So when you go for radiation for certain cancers or other parts of the body, that's not always stereotactic radiosurgery. Basically, the way we define radiosurgery is that it delivers a high dose of radiation to a target, and you do it over a very short treatment course length. Either you do it in one dose, which is the shortest course possible, or several doses. And of course, you want to achieve a very high degree of precision, because where you are typically treating with stereotactic radiosurgery is in a very challenging anatomical position, whether it's in the brain, in the spine, locations next to very important organs or eloquent areas, especially in the brain. The other point I wanted to make clear on this slide is that there are different names that will be thrown about, even within our own field, with reference to radiosurgery, and different acronyms that can be a little bit confusing. For example, there's SRS, which not surprisingly stands for stereotactic radiosurgery. In its purest definition, that means radiation is delivered precisely in one dose. So you come once, you get one treatment, that's done. And that's particularly, I would say, more appropriate when, especially we talk about trigeminal neuralgia and SRS. There's fractionated SRS, which basically is delivering the radiosurgery, but broken up to maybe 5 treatment doses. And in some occasions, you do that because of the target that you're treating either being larger or located next to a critical organ or a structure. That's still considered, a form of radiosurgery. And then the last term I included mainly because some colleagues in our field tend to use this because maybe it sounds sexier, because you can say saber, but it's stereotactic ablative radiation. It basically means the same thing as SRS or fractionated SRS. But so if you come across, if you're on Google or you're looking things up, in case you come across these things, hopefully that helps to clarify some of the definition there. Gamma Knife, again, it's one of many platforms, but why we like Gamma Knife, especially in the treatment of trigeminal neuralgia, is that it has a very, very long track history. The Gamma Knife, some people don't realize, was invented in the 1950s over in Europe by a neurosurgeon. And the initial intent was to treat functional disorders, including facial pain. So it really wasn't envisioned initially for tumors, but of course, that was a natural application of something like Gamma Knife. So sometimes people will ask, okay, well, if it was invented in the 1950s, is it considered old tech? Is this like an old technology? And the reality is it's not. If you think about it, cars in the 1950s don't look like cars nowadays. And that's the way I explain to the patients. the Gamma knife has gone through multiple iterations of improvements, but the underpinnings of its of how it's machined, how the design of the delivery of the radiation is done, for a patient has not really changed. And I think it hasn't changed mainly because it does it so well. It's very precise. It's important to know that Gamma knife, don't look at the name knife as an outright surgery. There's no cutting involved. In fact, uses very precise cobalt sourced beams of, I call them beamlets of radiation. There's 192 beams of cobalt 60 that are delivered very precisely in a hemispheric arrangement around the patient's head. And by doing so, and I'll have a slide later on to kind of depict this in an animation or an animated form, but this allows the radiation to be delivered with minimal effect on the surrounding brain tissue. It's a very precise and involved treatment modality, and as such, it involves a relatively large team of trained professionals. It starts with the neurosurgeon, the radiation oncologist. We have a physicist on site for every treatment, nurses and anesthesiologists to help, with any type of patient comfort. Here's kind of a typical treatment flow for a patient undergoing gamma knife radiosurgery. So generally, there's a head frame that may be placed by the neurosurgeon, and this is where the aid of the anesthesiologist can be very helpful to make the patient at ease and comfortable. Then we have to the right, we need to image. Imaging is very important because it serves as the foundation for target localization, treatment planning, and so that we can design the best treatment plan to deliver the radiation effectively but safely. Most times for a trigeminal neuralgia, this is going to be an MRI. In some patients that are unable to undergo an MRI, for example, if they have a non-MRI compliant intracoronary device, implanted device, we have CT techniques. But for the most part, most of our patients are able to undergo an MRI, and this gives us the best tissue definition. This might be small on everyone's screen, but for example, this is a patient who's undergoing treatment for right trigeminal neuralgia, and as you can see, the exit of the trigeminal nerve from the brainstem, as Dr. Brisman had spoken about previously, that is what we target. The typical treatment time for gamma knife radiosurgery for trigeminal neuralgia is somewhere between 30 to 60 minutes, give or take. It's a silent treatment. This panel on the left shows you sort of a cartoon depiction of what happens when the patient is actively being treated. So the first thing is that it's not a very confining treatment, not like an MRI per se. The opening is not that narrow. And the patient himself or herself does not go very deep into the machine, but you will see that the top of the head is engaged in this what looks like a cone at the head of the unit, and that's what houses those 192 beams of radiation that we were talking about. And these are all machined to actually focus the radiation on one single point, which can be as small as 4 millimeters in diameter. So we call that the isocenter. And that's what's being depicted in the cartoon on the right. You see basically all those beamlets that are coming out, and they all converge at that isocenter. And for trigeminal neuralgia treatment, we place that isocenter at that point of the root of the trigeminal nerve. Generally, we choose doses that have been tested in clinical trials and experienced over the last several decades. And generally a range of 70 to 90 gray. 1 gray is equivalent of 100 rads for those of you who are thinking in rads. But so it's a fairly high dose, but it's a very precisely small dose onto the trigeminal nerve. And again, our goal is to treat the root of the nerve. So like Dr. Brisman said, we don't necessarily choose which branch of the trigeminal nerve to treat. Our aim is to treat the entire nerve at its root. Some questions I typically get is how do we think radiation works in alleviating facial pain from trigeminal neuralgia? I show you basically a picture of a nerve cell that we might remember from high school biology, but I highlighted the myelin sheath, but because currently that's the running theory is that radiation, and remember, myelin is basically like a insulation for the nerve. It allows the conduction of the nerve and the signals running through the nerve to conduct very efficiently, much like insulation, let's say, on an electrical wire. But it's thought that the radiation disrupts the myelin of the nerve and thus makes the transmission of pain and sensation, those type of things, a little bit more difficult. And in research, that's what you see this panel on the right. This is called tractography. It's basically measuring the flow, if you will, or the conductivity of the trigeminal nerve before and after treatment. So you see the before in D, which is the lower left corner of that picture, and then in E in the lower right, there's disruption. And so that's the general theory, is that the radiation is affecting the conductivity of the nerve. So in terms of trigeminal neuralgias, for typical trigeminal neuralgias, we like to say about 75% of patients will report pain relief. Now, pain relief includes partial pain relief all the way to complete pain relief. Of course, we would love for all patients to have complete pain relief, but it's not practical to say that 100% will have complete relief. But about 75% of patients will derive some benefit, from radiosurgery. So I think it's not a coin flip, and it's something that's worthwhile for the appropriate patient to consider. In many reports, you do have durability beyond, 5 years, that a majority of patients will still maintain good pain control. There are patients, obviously, that do need potential repeat treatments. And a lot of studies have shown that in those patients that get a second treatment, perhaps, that the ability of the Gamma knife to provide pain relief, again, is in 75% of those patients. So good results, even if you have to go back a second time. And then there is often a delay or a latency of response. We just showed how the mechanism of radiation may actually affect the trigeminal nerve. That takes time. It's not an immediate effect. And I often quote patients, on average about 6 weeks for the pain to begin to respond. So not necessarily meaning that at 6 weeks, that they should know exactly where the treatment effect will be, but maybe they'll start feeling better and maybe can start their journey to starting to cut down the medications 6 weeks or a little bit after 6 weeks. Some side effects, from radiosurgery treatment for trigeminal neuralgia. So generally, it's pretty safe, especially in the patients who undergo the treatment for the first time. I call it a radiation-naive trigeminal nerve. Sensory disturbances like dysesthesias, sometimes like an underlying burning sensation, can be seen in about 10% of patients with contemporary techniques. And sometimes this is dependent on, the patient's dependent on your treatment team, knowledge of where to place the dose of radiation in the trigeminal nerve as it exits from the brainstem. Other side effects affecting the brain itself, like the brainstem or the brain itself, are usually rare, especially on the Gamma knife platform, just because of how small the collimation system is. So it's kind of a summary slide. Who might we consider for stereotactic radiosurgery for trigeminal neuralgia? So a lot of times patients come because they've been maintained on medications for a good while and it's been working, but at some point they start to begin to reach a threshold. They're either not getting the same amount of pain control on medications, or they get to a point where the dosages of medications have to be raised such that the side effects start to take over, and that therapeutic ratio between treatment relief and treatment side effects makes it less ideal. Patients who are not candidates for surgery, so patients who are on anticoagulation, can't come off of it, they're elderly, maybe they're more frail, or maybe they're just not interested in surgery, they can be considered for something like radiosurgery. Patients can come to us maybe having had other procedures, and maybe they haven't produced durable results and are looking for maybe a different approach. Radiosurgery can be a possibility for them. And like Dr. Brisman had said, it's considered one of the least invasive treatments out of the interventions that can be offered. And that's it. I offer my phone number here. Feel free to give us a call. We're very accessible. Thank you.
So I think we were now just going to take questions. If that's, I have some questions I could read off here that I got from
Yeah.
people. If that's okay, or you want to ask
Yes.
questions, go ahead. And yeah.
Thank you so much for the incredibly informative presentations, Dr. Brisman and Dr. Wu. And I'm excited to have Ivan join us this evening here in our conversation with answering the questions. There were several that were actually submitted in advance of this evening's webinar, and then there have been many more come in this evening. So I'm excited to get this started. To kick off, I'll ask a first question that came in. If there's no compression, but the patient has an autoimmune condition, which could be attacking the trigeminal nerve or affecting the trigeminal nerve, would the panel advise a different or better medication for these patients who do have these underlying conditions?
Ivan, go ahead.
Ivan, you're muted.
Ivan.
Yeah, sorry, I forgot to put on the mic.
No worries.
Okay, everybody can hear me?
Yeah.
Okay. So yeah, very often there is no compression of the cranial nerves. So what we do in clinic here, the number one probably goal will be to make sure there's something else is not causing that facial pain. There's many like secondary manifestation of the trigeminal neuralgia. And as Dr. Brisman mentioned in his slides, multiple sclerosis probably will be leading these causes of the trigeminal neuralgia. Other like connective tissue disease, rheumatoid arthritis, lupus. I saw in my residency and fellowship patient with a sarcoidosis and lupus. I remember one very distinct case when I was at the University of Virginia doing my fellowship, neurocritical care. We had a man in clinic actually with trigeminal neuralgia. And then, like 3 months later, he appeared in our neuro ICU in coma. Apparently, nobody know what was happening. And always when somebody comes in coma to neuro ICU, we do all of the tests possible, including spinal tap, and we send all of the possible tests. And one of his tests came positive for antibodies called anti-Hu antibodies, which is usually go along with brainstem encephalitis. And brainstem encephalitis, the leading cause of this like small cell carcinoma of the lung. So started from the trigeminal neuralgia, we actually got him out of the coma, and we found that he has a cancer in his lungs. That was very interesting case. We got lately pulmonologists, oncologists on a case, and the man actually survived. What are the causes? There's many, especially nowadays. I got a patients. I just had recently a couple, a wife and the husband. Husband went for the dental procedure and implants, and probably a few days after implants, he came to me with a severe pain in one side of his face, where actually was placed 3 implants on one side. And this was the cause of his pain, and the inflammation from this just placing implants was spread to the trigeminal nerve. And what I found out recently, actually, dentists, some of them, and not all of them, they do the CAT scan before they put the implants, and they see what the branches of the trigeminal nerve are, and they have to be a certain distance from that branch. Otherwise, people will have a pain. Usually when inflammation goes away, a few weeks takes, we have to treat them as a trigeminal neuralgia, but then everything goes away. That's like a good cause of the trigeminal neuralgia. Um, and Mike Brisman probably had in his experience, different tumors can cause trigeminal neuralgia, as brain tumors and metastatic tumor from the breast carcinoma, colon cancer, rectal cancer. So we have to look for all of those before we establish diagnosis.
I think the main autoimmune that causes trigeminal neuralgia is MS,
Yes, I
and the
agree.
medicines, whether it's MS or not MS, are still the same. The first line is carbamazepine, oxcarbazepine. Second is gabapentin, and if the person needs treatment for the MS, that's fine. But the carbamazepine and gabapentin are still going to be the first line treatments for the facial pain.
I agree.
Thank you both so much for answering that question. This is kind of a follow-up along the same lines. Um, This person wrote in to say, I don't have classic trigeminal neuralgia, but I've been diagnosed with atypical facial pain, which I believe is an umbrella term for other types of facial pain. Is that correct? And then also, this person mentioned that they began experiencing the pain after they had a cataract removed from their eye and a new lens put in 5 years ago. Since then, they've had a constant dull pain, and it's masked by her taking gabapentin between 1 to 3 times a day, but sometimes it doesn't make the pain go away and it becomes acute near her temple. Could you talk a little bit about, kind of what atypical facial pain means when doctors use that term, and then also maybe weigh in about how someone could experience pain after having an eye surgery?
Well, first, I think one has to distinguish between atypical trigeminal. So people define things differently, but in my mind, atypical trigeminal neuralgia is trigeminal neuralgia. The people have sudden, brief, severe electric shock or stabbing pains, triggered, go away with carbamazepine, but they may have some other features. But those patients should be treated like trigeminal neuralgia. Atypical facial pain, at least the way again classically defined, means it's some other type of pain, usually constant, dull pain that we may not know what it's caused from. So what you're describing here, you could call it atypical facial pain. You could call it nerve injury pain if it's after a cataract. But, anytime you have any procedure done to you, you're manipulating tiny nerves. There are tiny nerves all over our body that can sometimes get injured. And sometimes the pain can manifest at a distance. You could have an operation on your toe and then your whole leg hurts for reasons we don't completely understand. But this is not trigeminal neuralgia, should not be treated like trigeminal neuralgia. I mean, the gabapentin that you're taking, perfectly reasonable. One could either think about increasing the gabapentin, adding something else like Cymbalta or Elavil, trying acupuncture, Botox, topical pain creams, a whole host of other things. I'll ask Ivan if he has any other ideas, but this is not trigeminal neuralgia and should not be treated like that. But there are other things that one could do to try to help you. Ivan, any other ideas?
I absolutely agree with you, Michael. Usually, what from my experience we see here, and I talked actually today to my partner, Dr. Neistat, usually this patient has like poorly defined symptoms. Some of them will have more, but they still have that pain and all of those features of trigeminal neuralgia. I noted from my experience, this pain is more persistent. That's why sometimes we call this typical persistent idiopathic facial pain. But I agree with you, the treatment remains the same. The number one is carbamazepine Tegretol. We use gabapentin. And what you mentioned, we have acupuncture in our office. We use a lot acupuncture, and acupuncture helps. Probably like 50%, I would say. And other medication, anxiolytics like amitriptyline, we use for, but the number one, the drug of choice still is carbamazepine, gabapentin.
Thank you. You mentioned there acupuncture offered as a treatment within your office. Can you share any information about the use of, maybe other complementary or alternative therapies to help treat facial pain or even to help patients cope with their facial pain?
Well, uh, many people with especially long-standing trigeminal neuralgia, they developed anxiety. Many of them developed depression. So along with the neurologist, they will see the psychiatrist. Psychiatrist gives them their own medication. So that's important. And well, people use different, like some of them use like Chinese facial massage, which as long as it helps, I agree. Whatever they do, um, different remedies. So I'm not promoting anything, but I had a patient who said I tried everything, but then some chiropractor gave me CBD oil, and that helped. So I have no argument. Whatever helps, it helps.
People should also understand with pain, chronic pain, or any problem you have in life, every problem is two problems. It's the problem, like the pain, but the second part is that it bothers you, and that there are a lot of treatments that can focus on making it less bothersome. The gabapentin, for example, is good in that it not only treats pain, but it makes it less bothersome to you. Anything that reduces, as Ivan mentioned, anxiety, stress, improves your mood, doing things that you like, taking a hot bath, playing nice music, anything that distracts you or keeps you busy. Some people even use like little marijuana gummy at night if you had
Yes.
time. But important to understand there's a lot of things that can be tried, and don't give up and don't lose hope, and just you got to just keep trying.
Well said. And thank you so much for touching on those, additional options that might be available, especially, medical cannabis. Thank you so much for bringing that up as well. To switch gears a little bit, someone also submitted a question, and this is the last before tonight's webinar, and then there are several again that have been added during the webinar. If there's damage to the nerve from Gamma Knife, is it reversible? Or is there a progression of damage over time? Does it ever stop?
Leister, you want to?
Right. So, nerve damage is always hard to predict in terms of, when you perform radiosurgery, let's say for gamma knife, for trigeminal neuralgia, and, the patient, has some kind of a sensory disturbance. We often will take the approach that it takes time, so let's give it time first, because, a lot of the literature seems to suggest that it's maybe in the long term, meaning several years, that nerves may regenerate, they may regrow. In the meantime, though, with some of those bothersome side effects, from the sensory disturbances, you could try medications, much like what Dr. Brisman and Dr. Mikolenko were talking about. Gabapentin could be something that could be tried. You do want to make sure that you take measures to prevent corneal abrasions, if you have dry eye because of symptoms and side effects on that side. But it's one of those things. I mean, if it happens to you, obviously it's something that has to be managed. But it's not something that's common. And so I think there's a lot of variability in what's been reported in the literature about the recovery rates, and some reports will say maybe 1 out of 3 with sensory disturbances after radiosurgery will regain some of that capability or have reduction. But that means that there's a good degree of patients that have it that will still have to deal with it. So, Mike, I don't know if you have any input on that as well.
It may well improve with time, but again, it can definitely take time. Gamma knife, you may not see the numbness and stuff for years, and then with time, it may well improve. Not only might the numbness improve, but it may become less bothersome, which is just as important. Certainly, the eye drops and seeing the eye doctor is important if there's numbness in the eye to avoid corneal injury. Medicines, like we mentioned, gabapentin, Elavil, Cymbalta, the stuff that's going to make it less bothersome. And then, one of the things that I think might make a good study, which I haven't done yet myself, is the use of hyperbaric oxygen. Yes, that we use for people who get radiation on tumors and have a lot of, side effects. Again, if somebody had really, really bad side effects that I couldn't manage with anything else, I might offer that. There isn't really much evidence about, but it's something that in theory is good for radiation injuries. But usually, again, it's not that common. It's that bad. Usually we'll get better with time, and usually we can manage it with medicines. But yeah.
Thank you. Thank you for answering that question. There's a similar question here from the participants tonight. Someone who's had CyberKnife treatment for their TN and experienced total numbness on the left side of their face. They're asking what treatments are available for this. And I know you've mentioned some medications as well as the potential of trying a hyperbaric chamber. They've lost almost all taste, just all sensation on the left side. Do you have any recommendations for them?
Again, eye drops, seeing the eye doctor, doing all the things we mentioned, that's going to make you feel better, like gabapentin, Elavil, Cymbalta, reducing anxiety, stress, depressed mood, any of those things, knowing that it may well improve with time, the possibility of hyperbaric. But I think all the things we've mentioned, I'm sorry you're not feeling well, but again, certainly very good chance that with time, the numbness will improve and it may also become less bothersome. But I think, certainly not an operation, but medicines, coping measures like we mentioned, and maybe if it's really bad, despite everything, considering, a course of hyperbaric oxygen treatment, maybe.
Thank you. You mentioned previously, some studies or information out there, and maybe this is a good question for you, Dr. Wu. Someone is asking what the percentage of patients who get facial numbness after an MVD. So this is not talking about maybe the CyberKnife or other stereotactic radiosurgery, but microvascular decompression.
Oh, I think that's for Dr. Brisman then.
Yes.
MVD. Yeah.
Right. So I think it's a small number, but not zero. I think you also have to consider sometimes when we do an MVD, if we don't find a significant vascular compression, which sometimes we just don't, we purposely injure the nerve. Now, if you're purposely injuring the nerve during the procedure, then there's a much higher chance you're going to get some numbness because you're trying to injure the nerve. The other thing is that sometimes we will attempt an MVD on somebody with a very large blood vessel. I usually try not to do that, but if you try to do it on a very large blood vessel, it's also going to be a much higher chance that you're going to get numbness. Also, if you're doing a repeat MVD, where you're trying to, that's why I usually don't do repeat MVD or rarely do them, where you're trying to move the Teflon and the scarring away from the nerve, that's much more likely to injure the nerve and cause numbness. But a fresh MVD, where it's a small blood vessel, you're not trying to injure the nerve, I would say it's pretty low. And if there is, it's usually going to be not too much, but, it's never zero, certainly not zero.
Thank you. And here's another question for you, Dr. Brisman, about along the lines of MVD surgery. If the artery is touching the nerve, then why would the Teflon sponge not also create TN pain? Could you help explain why they use Teflon and how that wouldn't create the same situation that they are trying to solve?
Right. So, well, first of all, I think we use Teflon because it's a permanent material, and the way it moves at surgery, it's, certain materials just liquefy, certain materials disappear over time. So you want a material that's going to be firm enough that you can work with it. It's going to be permanent. Usually the problem is if the artery is really distorting the nerve. So, and ideally with the Teflon, like the example I showed you, you want to push the artery away so there isn't an artery or Teflon touching the nerve. Sometimes you can't sometimes because of the anatomy of things, the Teflon is going to end up touching the nerve, but hopefully it's not distorting the nerve. It's not pulsating on the nerve like the artery, but it is true that, it's a theoretical possibility, but usually with the Teflon that, again, ideally we keep the artery and the Teflon off the nerve, but even if the Teflon's touching it, it's more like a pillow, it's not indenting it and it's not pulsating on it. but it's not impossible that it could be an issue. That's why ideally it's best to have the Teflon not touching the nerve either.
While we're on the conversation of Teflon, there is a question from a gentleman who runs the Trigeminal Neuralgia support group on Facebook. And he says that he hears from a lot of patients interested in, having a Teflon-free MVD. Is this trend going to continue and be longer lasting than Teflon? More people are going away from foreign object situation being in their body. Could you provide any insights on this topic? Because he sees this, this question coming up a lot.
Yeah. So, most people are using the Teflon because, again, people have tried different things. I mean, the disadvantage of Teflon is that, it can rarely cause a little irritation, like what's called like a chemical meningitis, but usually it's not too bad. I usually put patients on 3 weeks of a low dose of steroid, and it's not an issue. The issue with the Teflon-free MVD, you have to do something to keep the blood vessel away. So the people who are talking about not using, I usually use Teflon, but if you don't want to use Teflon, you got to put something in there. So some people are talking about squirting in some fibrin glue, but I mean, the fibrin glue itself can sometimes produce irritation. It may not be as secure as the Teflon. So I kind of think that there are pros and cons either way. It may be that there may be something we could use instead of Teflon. And, some people suggested using muscle, and that's something that I might think of, that I might consider at some point. But the Teflon is pretty good. But I think if somebody wants to use fibrin glue or muscle, I think that's okay. But again, I'm not really convinced that is producing dramatically better results than the Teflon. And again, I would say much more important that you get the correct diagnosis, that the procedure is done properly with a very experienced person. And I think that that's the most important thing.
Thank you, Dr. Brisman. And here was another question that came in for you. What do you do for patients who've had all of the procedures you've mentioned, some more than once, but still have pain?
So one thought is maybe the person doesn't have trigeminal neuralgia. That's a possibility. If you've had all these procedures and no relief, maybe it's the wrong diagnosis. Number two, it's possible if you're still having pain that the pain isn't trigeminal neuralgia pain. It could be nerve injury pain. If you do enough procedures, a person can end up with numbness and achy pain as a result of injuring the nerve and not, but I would say, again, the issue is the person had multiple procedures and still has trigeminal neuralgia, which is possible. Like MS patients, you do rhizotomies, they start off with symptoms at age 40, and I've done 10 rhizotomies and they come back 3 years later, say, I have pain again. Another rhizotomy is perfectly reasonable if it's sudden electric shock trigeminal neuralgia pain. So if it's trigeminal neuralgia pain and they've had prior procedures, it may still be reasonable to consider another procedure. If it's not, then again, you go along the pathway of gabapentin, Elavil, other things, topical creams, stuff like that. But again, critical to determine, is it trigeminal neuralgia pain they have or not? And then, go from there.
Thank you, Dr. Brisman. And one point that you've really hammered home tonight is about making sure that you have the correct diagnosis. And I know typically patients first see a neurologist, like Ivan here. Thank you so much for being with us this evening. A question that came in is, how do you make that differential diagnosis of trigeminal neuralgia? If all the symptoms that were listed kind of on the slides shown this evening are present, what other diagnostic tools are used to confirm the diagnosis?
Well, a lot of it is the history. The history is the critical component. What is the person describing? The MRI is also important because the MRI can show, is there a tumor? Is there other signs of multiple sclerosis? Is there a big artery or a little artery that's touching the nerve or distorting the nerve? But a lot of it is the history. Some is the MRI, and having an experienced person. Again, I do believe that since I've seen thousands of people, that I will pick up on subtleties. And again, there are cases where it's obvious to everyone, like it's classic trigeminal neuralgia. Everyone's gonna, and people like sudden brief electric shock, Although even then, sometimes dentists make mistakes. That's why I lecture to dentists and encourage them not to pull all people's teeth out. And sometimes there are cases where it's obviously not trigeminal neuralgia. It's like someone says, well, I have a constant burning something, but there's a lot of stuff in between. And again, I do think that the experience of the person is going to be helpful. And anybody wants, do a little phone call or FaceTime with me for 10 minutes. And I can often tell you, because it's so important to get the correct diagnosis, because otherwise you're lost. You're just going down the wrong path. If you're not sure that what the diagnosis is, then you're in trouble.
I want just to add that usually people, before they come to me, they see at least two specialties, dentist and ENT doctor. That's probably the most common. They are thinking it's a toothache, then the other thinking that's a sinusitis. Right, Mike? So, and then they come to me or to neurosurgeon straight.
Thank you. Thank you for mentioning the fact that most people with facial pain do end up going to see their dentist or another specialist before they're properly referred to a neurologist and then a neurosurgeon who can offer them all of their treatment options. It is 8:01. I'm so thrilled to have all of you here this evening. There are so many more questions to get to, and we'll certainly be inviting Dr. Brisman, Dr. Mikolenko, and Dr. Wu back for additional conversations and to hopefully help answer all of your questions that you've shared with us this evening.
I just wanted to mention at the
Please
end,
go ahead.
it's very important that trigeminal neuralgia get treated, because if you don't treat it, it's going to get worse. The pain is going to worse. It's going to last longer. It's going to be more severe, and quality of life is going to go down. So whoever you see, Dr. Brisman, neurosurgery, neurologist, as a neurologist, is very important. Don't give up. Get treated.
Wonderful. Dr. Wu, Dr. Brisman, do you have any final words that you'd like to leave with everyone listening this evening?
Yeah,
There is,
I'm sorry.
just to say, there's a lot of good treatments we can offer you. We want to help, and don't lose hope, and keep trying to work on your problem. And I think, if you keep looking for answers, I think there's a good chance, you can find help, and we can help you. You just got to be persistent, but there's a lot of hope out there.
Yeah, I agree with that. I think it's important to have make sure that whichever professional you're with, a neurologist, a neurosurgeon, if you end up being with a radiation oncologist, that you have a balanced discussion of all the options. It shouldn't be the option that that particular professional does the most or only does, right? We want to make sure that we find the right treatment for the right patient. And like Dr. Brisman said, when you're able to kind of offer the patient, many of the options, then you can really have that balanced discussion and not necessarily have a certain bias one way or the other.
Thank you so much. And if people would like to reach out to contact you or hear more information, where should they reach you, Dr. Brisman?
You can reach me. My office is 516-255-9031. My cell phone is 516-319-7451. I'm on Eastern time, so you don't need to text me at 3 in the morning, unless you have to. My email is michaelbrisman@aol.com. It's just my name. And, and you can Google me, but we're here to help you anytime. And I say the most important thing we can do is just give you the right guidance, put you in the right direction, because being in the right direction is the most important thing.
Thank you so much. And this information and resources will also be available on our website at facepain.org, including a recording of tonight's webinar. Thank you so much for joining us this evening.
Thank you.
Thank you.
Thank you. Have a good night.
Bye-bye.